everyone, hope you're doing well. Welcome along to Spill the Beans. My name's Duncan Goldie. My guest this week is Dr Harriet Leyland, who, if any of you are active in these circles on LinkedIn, you will probably already know quite well. She's very active in posting kind of the different changes and innovations within the health tech economy from a clinical perspective. The reason for that is she is a clinician herself, still a practicing doctor in A&E, working as a physician, and she's also a healthcare consultant with her own healthcare and advisory consultancy. She's spent her whole career, ever since really she graduated and did her postdoctorate as an anaesthetist. She's been involved in innovative uses of technology and just different pieces within the healthcare landscape globally, to try and provide sort of a wider scale access to healthcare for the wider population. So really interesting to get her opinion on kind of the changes that are happening within the UK at the moment and what she's been involved with since most of us didn't even know what healthcare innovation was. So really good and informed, educated opinion to hear from. So I really enjoyed speaking with Harriet, and I hope you guys do too. Harriet, hi, thank you so much for taking the time to feature on the podcast today. How are you? Whereabouts in the world are you right now?
Hi Duncan, I am great. I'm based up in Derbyshire, and so I'm sitting at home as we all are at the moment.
Yeah, exactly. And what's the kind of I suppose pandemic work life been for you? Is it much different from normal? Are you normally based out of an office or like sort of traveling around?
Yeah, it's been a bit different. I sort of came in the beginning of this year, sort of actually kind of on a bit of a lull, and that ended up being really useful because then I suddenly was presented with having to homeschool. Prior to that, I was sort of traveling a lot down in London, probably 2 or 3 days a week. So yeah, no, it's been quite interesting. I haven't been on a train since March, which is very unusual. But I was working at home the other days prior to that, so sort of from that perspective. But additionally, actually, I've started doing clinical work again. So I've been back into the hospital, which I hadn't been prior to that for the previous five years. Haven't been doing face-to-face clinical work, so that's been a bit of a change, but also actually a really nice balance between the sort of sitting at home and spending too much time with my children to be able to actually get out and do something sort of immediately impactful, I suppose.
Yeah, definitely. I mean, just to kind of touch on that just straight away, I mean, what's the kind of clinical situation like at the moment? Have you been working in A&E, or where is it?
Yeah, no, so I've been doing A&E shifts, and it's quite interesting because I think so when I first started, so I went back in April, and the hospital was really quiet at that point, or certainly A&E was very quiet because people were really listening to that message of, stay home, protect the NHS. Then through the summer, it sort of built up, and by probably late August, it was a completely different situation and really worrying, actually, because as well as A&E being busy, both with people that, had the genuine need to be there quite unwell, not necessarily with sort of COVID symptoms particularly, but perhaps people who'd stayed away for the preceding few months and then had sort of, ended up needing to come in, more urgently. But also the hospital was full, and so then you get this real backlog in A&E because you can't move someone into a bed that's already got somebody else in it. And so I think when you're in that situation at the middle end of August, which would perhaps be normally your situation into October, November time, when you're expecting, the seasonal flus, etc. It is a concern, and it's quite concerning seeing sort of some of the stuff that's in the press about the hospital still being empty, because actually I don't think that's true anywhere in the country. I mean, I'm only working in one hospital, so I only get a snapshot of there. And I think there has been as well over the last few weeks sort of an uptick in the people coming in with respiratory illnesses that might be COVID. You know, I say might be because working in A&E, we haven't got the results of the test immediately, so we can just work on the presumption that it might be that. So yeah, it's been really interesting.
Yeah, definitely. I mean, it's I suppose it's evident immediately, right, based on your kind of career as to how you're seeing things firsthand as a clinician, but then you also have the time spent outside of that focusing on more kind of innovation and as you know, why you're featuring on this podcast, right, the digital side of that as well. So I guess to kind of, you know, go right back to the beginning, if you could just kind of talk me through a little bit of a snapshot of your career and kind of what's led you up into the position that you're in now.
Following my nose has led me to the position that I'm in now. So I started off sort of down the route of anaesthetics. So I did the postgraduate training in anaesthesia, got my postgraduate exams, and you know, people who are familiar with medical training, it's a long journey post your degree, which has already been quite a long journey. And so I'd got to that point about sort of 5 or 6 years into the anaesthetic training, and thought, do I want to do this for the next 30 years? And decided at that point that I fancied doing something different, and was really lucky at that point to have the opportunity to go out to China. And the idea was at that point that I would go into what I thought was a non-clinical role, which was working for a medical assistance company and working for clients who had, so employees working in China and the wider Asian region, and sort of sorting out their kind of healthcare needs. And that was, you know, anything from which GPs or which primary care service should we go to with our children, or you know, someone's had a horrific accident in a remote mine site in northern China. How do we get them, you know, out into a better level of care? But I did end up doing actually quite a lot of clinical work. So I was doing telemedicine at that point, and I was providing advice over the phone before I even, you know, realised that that was, you know, a specific thing. And it is really interesting, having sort of started doing that and thinking about the, you know, sort of particularly again with going back to COVID, you know, the sort of massive uptick of primary care doctors, GPs providing sort of telephone consultations. And that's been something that's been, you know, possible for, you know, as long as there's been telephones really, but it's been something that GPs, particularly in this country, seem to have been quite reluctant to do. And I can understand the reluctance, because obviously you get more information from a face-to-face perspective, and you can examine the patient, and you know, you're much less likely to miss something serious. But equally, in a lot of cases, you can provide what is required at that point, as long as you do put in appropriate safety netting. But yeah, so I worked out in China for about five years, and I did a variety of roles. And also in that time, I kind of was really exposed to the commercial side of healthcare business, and sort of working with the sales and marketing team in terms of, you know, how can we take our kind of products and services and make it work for different organisations whose employees have different health needs. And that's really interesting, because you're looking at both, as I say, the commercial bottom line, you know, actually, can we make money off this product? And often doctors aren't thinking about that, and particularly doctors in the UK who are working for the National Health System. You know, you're suddenly sort of, you know, how can we provide you know, services that work for your you know, your employers, your needs. And that might be because you're in a remote site somewhere, or it might just be that, you know, you want the best you know, output from your staff, and if we can manage their health, and if we can bring a flu vaccine clinic to them, then we'll reduce absences from, you know, our staff, and that's good for us. And so it's, you know, you're sort of thinking about medicine in a completely different way. I then went on and did about 18 months in Vietnam on a university campus. And again, it was that sort of combination of some face-to-face clinical work, but also thinking about kind of what the client needs were, what the sort of products and services, and how you kind of marry up that sort of health need, but also the kind of the business need. And during that time, I was doing a master's in global health policy with the, forgotten who it was now, London School of Hygiene and Tropical Medicine. And I thought, when I came back to the UK in 2015, I thought I was going to kind of go down that route and sort of be looking at global health and, you know, kind of how we improve health at a population level. And I've done little bits of work that sort of bridge into that area, but actually I've ended up working much more, and it's sort of developing more and more into the kind of digital health tech space. Part of that was I spent 2 years working for the Department for International Trade as one of their specialist healthcare advisors. And in that role, I had contact with so many different healthcare companies. Again, it was really eye-opening in terms of what comes under the kind of the banner of healthcare. Because I think, again, as you know, as a doctor, you sort of think, well, healthcare is, you know, GP clinics and it's hospitals and it's doctors and it's allied health professionals and it's nurses, and it sort of stops there. But in that role, I was, you know, working with architectural firms who were doing hospital design that was thinking about kind of patient flow through a hospital, or providing, you know, a better environment for, you know, promoting health, or facilities management, or, you know, kind of all sorts of things that you say that I wouldn't have traditionally thought of as coming under healthcare. But also at that time, I came across a lot of digital healthcare companies. And so it really, I think, got me thinking about how we can use the tech, and how we can use tech in a really smart way to kind of deliver better healthcare. So yeah, that was sort of, I suppose that's a sort of real summary of my journey.
Yeah, no, definitely. It's fascinating. Obviously, you've you know, developed a career which is, you know, as an advisor and as a specialist within an area which has now become, you know, one of the main sort of focal points globally about how, you know, patients in remote settings can maintain the same access to healthcare, and all the kind of things that you've been doing for quite a while now really seem to be sort of the most prevalent talking points within, you know, the health economy. So I guess to talk about, you know, more specifically the types of products that you're seeing, or the types of businesses that you've supported throughout, you know, recent history, what's your sort of qualifying criteria for these issues? I mean, there's so many digital health platforms and products now. How are you sort of qualifying whether or not they're going to be able to make an actual difference to the sort of wider population, like you said?
I mean, I think it kind of really comes down to sort of whether it seems like it's a good idea. That's probably, you know, not the sort of, you know, well-defined kind of, you know, I put it into this pathway and, you know, the algorithm spits out at the end whether it's going to work or not. No, much more done on sort of a sense of whether it seems like it's something that's going to be needed and has value. And I think that's a space where particularly the very early stage startups can struggle, because they might perceive a problem, but actually the problem that they've perceived may be a problem, but it might be a problem because there's something further downstream that's causing the problem, if that makes sense. And I think one of the big issues can be then you sort of develop this product based on, you know, your endpoint kind of theory as to where the problem is, but actually then when you try and say get that taken up by the NHS or, you know, or whatever, it doesn't quite work because you haven't solved the problem that's actually downstream. I mean, you know, that's sort of some of the things that I've been working on recently. So I both work sort of by myself as a consultant to companies, but I also work alongside some other bigger consultancy groups, because often or sometimes I can't provide everything that's needed by myself, and so I've got links into quite a few different consultancy or you know, other groups who are doing similar sorts of things. So some of the projects I've been working on recently, so I'm doing some work at the moment around medicines adherence, and that's with quite an early stage startup, and they've also got a product that's looking at a response to COVID, and basically trying to sort of, the COVID product is looking at how you can, it's sort of an immunity passport in some sense, but how you could use that to really get leisure venues back open, or open to a larger capacity of people. And medicines adherence is something that's really useful, because we've known there's a big problem with that for a really long time, and I think there's, you know, lots of potential issues with that, and looking at products that perhaps kind of nudge behaviour. I think that's been looked at, but what you've got the ability to do now, which I think is where it becomes more interesting, is linking both the electronic health record with something that the patient has access to, that's providing nudges, behavioural nudges, but also linking perhaps to Bluetooth devices, so that you can actually see what the impact is. And I think that's potentially something that makes you know, taking your medication suddenly, oh, I can see the value of doing this in real time, rather than waiting for oh, I've had, you know, another sort of, you know, I've had another mini stroke, or I've, you know, gone into hospital with chest pain again. Perhaps I should have been taking my medication. I've also been doing some work on patient monitoring in more complex pathways, so sort of patients with long-term serious conditions, some of the cancers we've been looking at. And again, it's the connection between how can this product help the clinicians manage that patient, perhaps with, you know, significantly less touch time in a clinical hospital environment, which we all understand is concerning right now, but it's also inconvenient for people. You know, if people are having to kind of take half a day to go and have an appointment, at which point they're told, oh yes, just continue on your medication, which is, you know, absolutely what does happen in the health system, then, you know, if you can do that via sort of collection and appraisal of data, and then, you know, perhaps a quick video call, or even just messaging, then that's brilliant. You know, that becomes part of the patient's life. And what I strongly believe in, and perhaps this answers your question before about what would be my criteria, what I want to see is, I want to see the patients taking more control over their health, and then ownership over their health. Because I think we've spent probably the last 40 years or so, although, you know, ever since I was at medical school, which was in the late 90s, early noughties, you know, we said, no, it's not a paternalistic model. We don't tell the patients what to do. It's a very much a, you know, shared decision-making process. That's quite difficult in a model where the notes are held by the doctor, where most of the treatments that are provided are perhaps a medication. You know, what's in that pill? You know, who knows? Whereas once the ownership and the control over that, and you can access and see the response to that pill, or you can, you know, see the response to the therapy and say, oh yes, my ability to do this or that or the other, my my quality of life has improved because of this intervention, and you're holding that information yourself, I think it makes a massive difference. And I think that's really important. I mean, the other thing I think is really important as well is not to jump over into digital and just say, right, we've got this model, we've shown that it works, this is what we need to do, this is the best model for everybody, and forget about the people that either can't access it that way or don't want to access it that way, or whose needs don't quite fit into a particular pathway or into a particular product. And I think that's incredibly important. And I think some of that information is really coming to the fore again now with, and I just was reading something this morning about concern about management of things like hypertension and cholesterol levels, because people haven't been accessing their face-to-face appointment with their GP. And yeah, that information ought to be able to be collected remotely. And in fact, my mum was given a blood pressure monitor by her surgery. Although when I say given, I think she was actually asked to go and buy it, which is potentially a barrier for some people. It wasn't particularly expensive, but it does provide, something, if your decision was, shall I buy this blood pressure monitor or shall I get food for the week? Which is that going to be? So, I think it's really important that alongside all this digital innovation and kind of putting all of these, new technologies in place, you remember that there has to be a way that it can still be offered as a either face-to-face service, or, there's other ways in which you can get people that might be struggling to access it still to, have access to that healthcare.
Yeah, it's definitely like a balancing act between, I suppose, the access to healthcare, like you say, but also the implications of, changing a method of treatment or diagnosis, and, who is actually going to be able to adopt that themselves. I guess kind of around the adoption piece, like there's also the other facet of just because a technology makes sense, it doesn't always have the right, commercial adoption, particularly within the UK, because of the kind of, I suppose, the layout of our national health system being quite insular in terms of what might work for one, remote place in Wales, remote NHS trust in Wales, might not have the same application or implication to the kind of patient pool in central London. I mean, with the work that you're doing, are you seeing that there's certain trends around certain themes, potentially around COVID or even prior to COVID, around, what kind of technologies are being, I suppose, adopted by the NHS, and vice versa, potentially not adopted as fast as they should be?
I mean, yes and no. I mean, I think it is really interesting. And I mean, the way that the NHS is set up is that, it's not a single organisation. Even in England, it's not a single organisation that, will decide to kind of take up a programme at a national level. Or, I mean, that does happen sometimes, but usually it doesn't. And, with the CCGs, now kind of also thinking about primary care networks, and as they're developing, I think you see power on a very localized level. And I think, I don't think that there's a particular kind of, I don't think you can easily say that this product will work in this area and this product won't, or vice versa. I think it can really depend on what's on the agenda of whoever is commissioning a service. I think it also depends, what you often need to do with, a new product or service is you need to gain evidence of that it can be effective, and you need to have shown that it's got a benefit and probably is also going to save money. And when you've worked in a, you might sort of have linkages with a particular CCG, and get a trial set up and show, yeah, look, we can use this product and service, and it does work and it is effective. Now that doesn't necessarily mean that you'll then once you're trying to sell this as a commercial proposition, that it will get taken up. Unfortunately, you know, the people working in the commissioning groups, they have to use their money in the way that they think is getting best value for money. And almost to some extent, if you've shown that, look, this works, that opens the door for other organisations to come in as well. I think it's really interesting as well, where you see sort of something working really successfully and think, why hasn't that been taken up by, you know, other areas? And I kind of sometimes get the sense that there's almost, well, if they're using it there, we kind of want to use something different. And I mean, that's a bit frustrating because, you know, both from a just from a pragmatic perspective, if something is working, wouldn't it be great for that to very quickly get, you know, adopted and taken up in other regions? And I mean, I think that's why organisations such as the Academic Health Science Networks are really important, or people like Innovate UK, who can support companies at an early stage and help them get introductions into kind of different parts of the NHS. And also, particularly with the Academic Health Science Networks, what they will do is, you know, if something is working really well in one area, they will share that knowledge and get that knowledge spread. So, you know, I think you do see things that will work in one area and might not work in another area. And that might be because of the priorities of the area. It might be because of the population. It might be, like you say, because if people are having to travel a really long distance in that particular region, the uptake from the population just, you know, is better than if actually it was as convenient for them to go into the surgery or into the clinic.
Yeah, definitely. It's good to have that kind of increasing variety of methods of, you know, treatment and diagnosis and everything like that comes into it. So at least people now have maybe slightly more options than they had, you know, even 10 years ago. We're almost out of time, but I guess just to kind of summarize, I mean, what are you kind of looking forward to seeing in the you know, I suppose predominantly UK healthcare market over the next few years?
I mean, I think there's so much interesting stuff out there. I mean, I think, you know, we were at a really interesting point at the beginning of the year, and then it's just kind of, the pace of change has just been absolutely exponential, which is, you know, I'm sure it's what everyone is saying. But I think where we are now, it's kind of it should be a point at which we really sort of take stock a little bit and say, look, what have we got introduced and how is that working? And what do we need to do to kind of make that more effective? And I think over the next, you know, year, 5 years, we're going to see, you know, a lot of really, really interesting stuff kind of coming. And I don't think that we'll have completely redesigned our health system in the next 5 years. And the NHS Confed Reset report that came out recently was quite interesting in sort of in the way that they approached, you know, what we need to do now. But I think you will definitely see a much larger proportion of the population taking much more responsibility for their health and having a much more, I mean, we use the word integrated healthcare in lots of ways. But I think they will have a much more integrated ability. So, you know, if I am using my Apple Watch to track my heart rate, or if I am using another device to monitor, you know, my health indices, that my ability to share that with my GP or my clinicians, whether that be from an app that they've developed and are pushing out to me because of a particular condition, or whether that's because of, you know, just information that I'm collecting on, you know, on my phone myself. I think that will all become much more built in. I think that the UK health system will become much more able to kind of cope with that and manage that. But I think there's a lot of work to do to get us there. You know, I think we're very much sort of a few pieces of the jigsaw now, and it's kind of fitting in the infrastructure around that, I suppose.
Yeah, definitely. Definitely. Well, look, it's been fascinating to hear everything from your perspective, and obviously a very well informed perspective as well. So if anyone does kind of want to, I know that you're posting quite a lot of stuff on LinkedIn and places like that. If people do kind of want to keep an eye on what your views are, what's the best way for them to stay in touch?
Yeah, I think probably through LinkedIn is probably the best way.
Okay, fantastic. Well, we'll share a link to that just in the summary of this podcast. But for now, Harriet, thank you so much for taking the time to chat with me. And really excited to see kind of everything that's developing, like you mentioned, over the next few years.
Great. Well, brilliant to talk to you. And let's keep in touch.
Definitely. Thanks, Harriet.
Okay.
So that's it for this week then, guys. Thanks very much to Harriet for taking the time to chat with us. As mentioned, she's posting a lot at the moment in terms of all the different changes within the UK healthcare system. So it's really worth following her on LinkedIn if you're not doing so already. I've put a link in the summary of this podcast to her profile, so you can check it out there. Apart from that, stay well, stay safe, and I'll see you guys next week.
Spilling the Beans Digital Health Podcast is aimed at members of the digital health community globally, with guests from the United Kingdom, Australia and the United States. The podcast is available through all major podcast distributors as well as on YouTube. The show is sponsored by Woodrow Mercer Technology and Woodrow Mercer Digital Health.